Many patients arrive in the hospital to the emergency room, or they're already on the wards and they're in reasonably good condition, but they deteriorate. And we need systems for identifying the deteriorating patient. Sepsis screening tools and early warning scores are systems that are now used in the majority of hospitals to identify patients before they become critically ill and hopefully allow for interventions that will prevent those patients from ending up in the ICU. This tutorial looks at those scoring systems and also mentions intensive care scoring systems. Introduction to critical care. Part 3. Identifying critical illness. Welcome back. In the previous tutorial, I discussed why patients are admitted to critical care. I discussed the concept of physiologic reserve and how physiologic reserve diminishes with age and disease. I also explained how duration of stay is determined by the timing of diagnosis and therapy. In this tutorial, I will discuss how we can identify or pre-identify patients who are critically ill or at risk for becoming critically ill. And the key component to this tutorial is a discussion of early warning scoring systems. First of all, I think it's time to define critical illness. Critical illness is a disease syndrome characterized by abrupt loss of physiologic reserve such that the patient requires life-sustaining measures. You're called to the ED to see Michael, who's a 28-year-old electrician who cut his hand last week. He licked the wound and put on a bandage and kept working. Today, his hand is sore and throbbing. A nurse in the ED doesn't like the look of him. Is Michael critically ill? On the ward, you see Emily, 72-year-old, who has undergone an open elective aortic aneurysm repair. Intraoperatively, a suprarenal aortic cross clamp was placed. She was brought back to the ICU, mechanically ventilated, extubated the next day, and sent to high dependency and subsequently the ward. Was this patient critically ill? She was in the ICU after all, and the HDU, but she was never critically ill. She underwent major surgery with a predictable perioperative stress response. Intensive care monitoring and interventions were required, but all of this was controlled. We're back in the ED. We see Podge, who's 52, who has developed a dry cough and fever. He's tachypnic. He's admitted through the ED with pneumonia and treated with intravenous antibiotics and 40% oxygen. Is Podge critically ill? Well, you can tell from the previous tutorial that Podge just requires level 0 care. He needs IV antibiotics and oxygen. This can be delivered on the ward. He is not critically ill. However, 5 hours later on the ward, Podge deteriorates. He becomes confused and severely tachypnic with a respiratory rate of 45. A non-rebreather face mask is placed. His saturation on pulse oximetry is 82%. His temperature is 40 degrees Celsius. His blood pressure is 80/40. Is Podge critically ill now? I would argue that he is. He's requiring multiple levels of life-sustaining therapy, and he is clinically unstable. Emily is now post-op day 7 on the ward. She suddenly becomes confused. Her heart rate rises to 120 beats per minute. Her respiratory rate rises to 30 breaths per minute. Her blood pressure falls to 88/50. Is Emily critically ill? I would argue that she is. She is showing evidence of multi-organ dysfunction. Let's go back and see Michael, the 28-year-old electrician. Remember, he cut his hand last week, licked and bandaged it. Today his hand is throbbing and he decides to go to the ED. The nurse didn't like the look of him, but there was no way to quantify this. Later, he starts hallucinating and ranting. He is cold and clammy and sweating, and his pupils are dilated. Now Michael is at the bus stop waiting for the bus. He can either get on the bus and get treated in a timely fashion and do well, or he will miss the bus. But I can tell you, Michael is septic. He's shouting it all over the place, and it's up to you, the healthcare provider, to recognize that he's septic. Well, what happened to Michael? He became severely confused, talking nonsense. He started seeing things. He was a bit aggressive. His heart rate was 96, his blood pressure 96/50. His respiratory rate was 22. He is seen by the ED resident, who decides that Michael must be a drug addict or an alcoholic who's withdrawing or is psychotic, and he calls the psychiatry resident, who is unavailable. Michael has missed the bus. 6 hours later, he's found in bed, moribund, blue all over. His heart rate is 150, his blood pressure is 60/40, and his fingers and toes are black. Michael is critically ill now with septic shock. He gets resuscitated, he gets mechanically ventilated, but he will have a slow, undulating course with horrendous morbidity. Subsequently, Staph aureus was found growing in his hand wound site. The key point to make here is that timing matters. Michael, whose sepsis was missed, will have a prolonged duration of stay in the ICU, going to high dependency with a long time for recovery. He will probably need amputation of fingers and toes, and he will never work again as an electrician. Had his sepsis been identified at an early stage, he would have had incision and drainage of his hand abscess, got his antibiotics early, gone to a ward, and been out of the hospital within 7 days and back at work in a week. So the key thing to ask yourself is, if I see Michael in the ED and the nurse is saying, I don't like the look of him, how do we identify the critically ill or deteriorating patient? Because heuristics are all very well, but for a nurse to spot that the patient doesn't look well, you require an experienced nurse. It also requires a responsive doctor who listens and executes. It requires a system for escalating patient care, because lots of patients fall through the cracks, and the first sign of trouble may be a cardiac arrest or the situation that Michael was in. Now, there are simple systems that you can use for scoring a patient. One of them, for example, is the quick SOFA score, Sequential Organ Failure Assessment Score, that uses 3 things for identifying sepsis: altered mentation, that's a drop in the Glasgow Coma score; blood pressure of lower than 100 millimeters of mercury systolic; or tachypnea with a respiratory rate of greater than 22. If the SOFA score is greater than 2, you think sepsis. So if you look at Michael, he was confused, his blood pressure was less than 100, and his respiratory rate was 22. So a quick SOFA score would have identified his sepsis. In virtually every hospital in the world these days, sepsis screening is part of patient management, and every hospital will have some form of screening system for sepsis. This is the sepsis form that's used in our hospital. And it's essential that if sepsis is considered, then this screening system is used depending on how it's performed locally. But it invariably involves giving the patient intravenous antibiotics, intravenous fluids, and if necessary, oxygen, and certain blood tests should be sent to full blood count and blood cultures. I want to backpedal now and look at the interactions between doctors and nurses on the wards. Nurses everywhere in the world are trained to perform a limited series of clinical observations on their patients, and they call doctors when abnormal observations trigger concern. The kinds of anomalies that are encountered are based in different systems. For example, in the respiratory system, the patient may present with respiratory distress, manifest as rapid shallow breathing, slow shallow breathing, obstructed breathing, or hypoxemia on pulse oximeter, or if the patient is on end-tidal CO2 monitoring, hypercarbia. In the cardiovascular system, the patient may manifest tachycardia, bradycardia, fast heart rate, slow heart rate, arrhythmias on the ECG if the patient is receiving telemetry, hypotension or hypertension. With respect to the neurological system, the patient's mental status may change. There may be a reduction in the level of consciousness, or the patient may become agitated or delirious, or may have seizures. The other system that is commonly monitored is the kidney. And in terms of renal function, the clinical signs are usually low urinary output, which is oliguria, or no urinary output, which is anuria. The other thing that the nurses check at the bedside is the temperatures. The patient may have a fever or they may be hypothermic. These clinical criteria have been consolidated into a series of early warning scores that have been widely adapted throughout the world. The scores use easy bedside observations, the respiratory rate, the peripheral oxygen saturation, whether the patient requires supplementary oxygen, the heart rate, the blood pressure, the level of consciousness, and the temperature. And deviations from normal results in a score, and the degree of deviation scores 1, 2, or 3. The higher the score, the worse the deviation. All of these different systems scores are compiled together to create a single early warning score. The purpose of the score is to identify the deteriorating patient before they become critically ill. This is the UK National Early Warning Score, or NEWS, and this is the Irish Early Warning Score system. And you can see they're pretty much the same, slightly different colour scheme, but more or less the same way of scoring. So Michael, based on his heart rate of 96, blood pressure of 96/50, confusion, and a respiratory rate of 22, would yield an early warning score of 7. Now, what do you do when you get an early warning score of 7? The first thing is to know when not to use it. It shouldn't be used in the operating room, recovery, or critical care, because in those locations abnormal physiology is to be expected, and what you don't want in the patient's chart is an abnormal early warning score that someone can go, oh no, it was like this earlier on when they were in recovery. So it shouldn't be used in those locations. It's really a standard of care on the ward and certainly can be used in the emergency department. A new early warning score of 3 should trigger a call to a doctor. An early warning score of between 4 and 6, for example 5, should trigger a sepsis evaluation. An early warning score of 7 should trigger an escalation call, for example, to the critical care team. And this is what it looks like on our early warning score chart. Remember, 4 to 6, think sepsis. It's a fantastic system, and the reason why it's great is that it controls all of the junior people and all of the people who lack confidence, because they know they must escalate if the patient hits a certain level. They can't refuse to do it, and also they don't feel embarrassed about calling in case they humiliate themselves, because it rigidly locks them into the system. There are a number of critical illness scoring systems, one of which can be used to identify the deteriorating patient who is already in the ICU, and that is the SOFA score, Sequential Organ Failure Assessment Score. It's been around a long time now, and it looks at scores for dysfunction in 6 different systems: the cardiovascular system, the central nervous system, the respiratory system, the kidneys, the liver, and coagulation. The systems will score a 0 up to 4 for each system. For example, the respiratory system uses oxygenation, the PaO2-FiO2 ratio. If the patient develops hypoxemia, it progressively increases their score from 1 to 2 to 3 to 4. The minimum score on the SOFA scoring system is 0. Obviously, you would never be in the ICU with a 0 score. Usually, most intensive care patients will have a score in excess of 7 or 8. The maximum score is 24, and the higher the score, the lower the chance of survival for the patient. Realistically, anything over 15, the patient is at very, very high risk of death. If we look at the SOFA score of Paddy, who is 73, who came in with community-acquired pneumonia and now has multi-organ failure, his SOFA score today is 19, and that's extremely high, and it means that he is very unlikely to survive critical illness. Now, there are a number of other critical care scoring systems, the most important of which is Apache. Apache 2 and Apache 3 are acute physiology scores that are used to quantify the condition of patients as they arrive in ICU, and this is really helpful for comparing outcomes across different hospitals and different populations. There's a simplified version of this known as the SAP score. There's a scoring system known as TISS, which is Therapeutic Intervention Scoring System. That's used to look at the amount of work nurses have to do, and there are also a variety of different morbidity or mortality prediction models. The Other scoring systems may look at patients in perioperative care, patients who had liver failure. There are legion other scoring systems out there, but most of them are on this picture. Now let's review this tutorial. In this tutorial, I discussed why timing matters in the diagnosis and treatment of acute critical illness. I discussed how to identify the critically ill patient, the kind of things that you get called to on the ward when patients are becoming critically illness, how all of this has been consolidated into a single number known as the early warning score that is combined with sepsis screening, and the SOFA score in the ICU that looks at multi-organ dysfunction syndrome. In the next tutorial, we're going into the ICU, and I'm going to explain to you how to examine the critically ill patient. It's quite different from how you assess patients on the wards or in the ED. It's a little bit more complicated and needs to be quite systematic. I'm then going to go through how you present patients on critical care rounds. It needs to be systems orientated. I'll see you then, and I guarantee you'll learn something. Well, this is a tutorial on early warning scoring systems. These are a tremendous asset in modern clinical practice and have avoided many admissions to critical care. Next time we're going into the ICU and we're going to discuss how you evaluate and present patients.